Welcome to the Deep Dive Ortho, the show where we unpack complex medical topics for discerning professionals. Today, we're diving deep into a condition that presents a unique challenge for young athletes: gymnast's wrist. Now, this isn't just a colloquial term, it's a recognized overuse syndrome, clinically referred to as distal radial physeal stress syndrome, or sometimes distal radial epiphysitis. Our mission today is to thoroughly dissect this prevalent condition, from its intricate underlying mechanisms right through to the precise diagnostic methods we employ, and, crucially, the comprehensive return to sport strategies that, well, every medical professional overseeing these athletes really needs to master. And joining me to navigate these depths is the brilliant Prof. Mo Imam, whose orthopedic insights and ability to synthesize complex information are truly second to none. Okay, let's unpack this.
Thank you. It's a real pleasure to be here. You've highlighted a critical point straight away. Wrist pain in gymnastics is, well, it's incredibly common. It's so prevalent in the sport that it's earned its own specific designation, gymnast's wrist. And this arises directly from the unique biomechanics of gymnastics, where young athletes spend an extraordinary amount of time supporting their entire body weight on their hands, often in highly hyperextended positions. This constant, repetitive loading, particularly during crucial growth phases, creates a sort of perfect storm for injury. And without proper, timely intervention, this condition has the potential for significant long-term complications that can profoundly impact an athlete's career and indeed their long-term skeletal health. It truly drives home how vulnerable these growth plates can be.
That immediately underscores the importance of our discussion today. So let's start at the very beginning for our orthopedic practitioners listening in. What exactly is gymnast's wrist at a clinical level? Can you give us a clear anatomical breakdown that helps us understand its specific vulnerability?
Certainly. Clinically, gymnast's wrist is defined as an overuse syndrome, specifically affecting the distal radius. That's the larger of the two forearm bones, the one on the thumb side, where it connects to the hand at the wrist joint. Now, the crucial anatomical target here is its physis, or, as it's more commonly known, the growth plate. To fully appreciate this, if you picture the structure of any growing long bone, you have the main shaft, the diaphysis, which widens towards the ends into the metaphysis. The very end of the bone is the epiphysis. And positioned precisely between that metaphysis and the epiphysis is this area of specialized cartilage, the physis. Its primary function is quite remarkable, really. The engine room, responsible for creating new bone, allowing the limb to lengthen as a child grows.
Right, the growth engine.
Exactly. Now, here's the critical vulnerability. Unlike mature bone, the physis is composed of cartilage. It's a significantly softer and inherently weaker structure. This makes it particularly susceptible to stress and overuse injuries, especially under the kind of, well, superphysiological loads we see in gymnastics. And when we talk about the radius and ulna, the two bones of the forearm, it's typically the distal radius that bears the overwhelming majority of the axial load transmitted across the wrist during weight-bearing activities. This anatomical predisposition makes it the prime candidate for this specific type of injury in young, growing athletes.
Understanding the what is vital, as you've just articulated so clearly, but let's delve into the why. Given this anatomical vulnerability, how do these unique gymnastic demands translate into such specific injuries at the growth plate? What are the precise mechanisms at play here?
Yes, the mechanisms are directly tied to those unique biomechanical stresses inherent to gymnastics. As I mentioned, the wrist in gymnastics is frequently used as a primary weight-bearing joint, and often in positions that involve extreme hyperextension, think handstands or vaulting. This subjects the distal radial physis to superphysiological loads, far beyond what it would typically experience in daily life. Just imagine the repetitive high-impact activities like tumbling passes or vaulting landings. These transmit significant compressive forces directly across these vulnerable growth plates. What ensues is a chronic cycle of microtrauma and inflammation at the growth plate of the distal radius. It's not usually a single acute event, but rather the cumulative effect of thousands upon thousands of these micro-impacts.
So it's that constant pounding, essentially.
Precisely. Now, here's where the long-term consequences become quite severe and truly necessitate our attention as orthopedic professionals. If this repetitive microtrauma is left unaddressed, or perhaps more commonly, if the athlete continues to push through pain, it can lead to premature closure of the distal radius growth plate. This means the growth plate turns to bone earlier than it should, effectively halting the radius's longitudinal growth. The serious complication then arises because the ulna, the other forearm bone, typically continues to grow normally. This disparity in growth leads to what we term distal ulnar overgrowth, or positive ulnar variance. When the ulna becomes relatively longer than the radius, it fundamentally alters the way force is transmitted across the wrist joint. Instead of the load being distributed nicely, the ulna starts to bear more weight than it's designed for, which can lead to chronic wrist pain, impingement, and other degenerative changes later in life.
And you mentioned this isn't rare.
Far from it. It's thought to affect a significant proportion of young gymnasts, with incidence rates cited between, say, 25% and 40%. It particularly crops up during periods of intensified training when that cumulative stress is really at its peak.
That's a truly startling incidence rate, really highlighting how critical early detection must be. So when a young gymnast presents in a clinical setting, what are the telltale signs and symptoms that we as practitioners should be specifically looking for? And what are the key elements of the physical examination that will help us confirm our suspicions?
Indeed, early recognition is paramount to mitigate those long-term risks we just discussed. From a symptomatic perspective, the most common complaint you'll hear is chronic, intermittent wrist pain. This pain is almost always localized to the radial side of the wrist, that's the thumb side. It's particularly aggravated by any activity that involves weight-bearing through the hands or high-impact loading of the wrist. Think of skills like handstands, L-holds, or back handsprings. These are classic provocateurs of pain in affected gymnasts. Some athletes may also report visible swelling around the wrist, and they often experience pain when you apply direct pressure or squeeze around the distal radius right over that growth plate area. You might also notice a decrease in their overall wrist motion, especially into wrist extension, which is obviously crucial for many gymnastic skills.
And does the pattern of pain change over time?
Yes, the progression of symptoms is also quite telling. Initially, the pain might only manifest during high-intensity training sessions. However, if the condition progresses and, crucially, is ignored, the pain can worsen to the point where it occurs during regular, non-gymnastic daily activities. And in severe cases, it can even persist at rest. While it's rare, some gymnasts might report associated numbness or tingling in their hand, possibly indicating some nerve irritation.
Okay, so that's what we're listening for. What about the examination itself? What are the key findings?
Right, the physical examination. Several key findings will guide your diagnosis. First and foremost, you'll almost certainly find localized tenderness to palpation directly over the distal radius, specifically targeting that growth plate area. Visual inspection might reveal some subtle swelling, perhaps. Range of motion assessment will often show a noticeable decrease in wrist extension, correlating with their complaints. And a very specific and highly indicative clinical test is the positive L-hold test. This is where the gymnast experiences pain in the wrist when asked to perform an L-hold, which involves supporting their body weight on their hands with straight arms and legs lifted in an L shape. These combined clinical signs and symptoms, well, they paint a pretty clear picture of gymnast's wrist.
That comprehensive clinical picture is invaluable. But beyond the clinical exam, we know that imaging is absolutely crucial for confirming the diagnosis, assessing the severity, and really guiding our management. What are the essential imaging modalities you rely on, and what specific findings should we be scrutinizing in the radiographs?
You're right. Imaging provides that critical objective confirmation and helps us understand the extent of the injury. For initial assessment, standard radiographs or X-rays are always the first line. We typically recommend AP and lateral views of the affected wrist. In many cases, though, it's also highly beneficial to obtain contralateral X-rays of the other wrist for direct comparison. Specifically, PA 90-90 lateral and oblique views can be helpful. This allows us to assess for any asymmetry in growth plate appearance or bone length, which can be subtle.
And what are we looking for in those X-rays?
We're looking for several key findings indicative of gymnast's wrist. You might observe a widened distal radial growth plate, which suggests disrupted enchondral calcification, basically. The normal bone-forming process is being interfered with. The borders of the physis might appear ill-defined, rather than sharp and clear like you'd normally expect. There can be irregularities at the growth plate itself, indicating that chronic stress. In more severe or chronic cases, you might even see early signs of premature growth plate closure, which can manifest as a sort of bony bridge crossing the physis. Other findings can include distal radial physial sclerosis, a hardening of the bone around the growth plate, and sometimes a characteristic parrot-beaked appearance of the distal radius. And crucially, in chronic and advanced cases, radiographs will often reveal that positive ulnar variance, where the ulna appears longer relative to the radius, due to that differential growth we discussed earlier.
Okay, so X-rays give us the bony picture, but what about MRI? What specific advantages does it offer here? And is there anything groundbreaking happening in MRI protocols for gymnast wrist?
Ah, MRI. Yes, this is where we gain much deeper insight into the soft tissue and early bone changes that simply aren't visible on X-rays. MRI is usually indicated in more chronic cases or in those patients who aren't responding as expected to initial non-operative treatment. It's also useful when there's concern for other coexisting injuries, like a triangular fibrocartilage complex, TFCC tear, or perhaps a scapholunate ligament injury, which can sometimes present with similar pain patterns. MRI also allows us to quantify the true degree of gymnast's wrist by visualizing changes within the physis itself.
So what kind of changes are we seeing on MRI?
Key findings include things like paraphyseal edema, which is essentially fluid accumulation around the growth plate. We might see early physeal bridging, signifying the very beginning of that premature closure process. You might also see bruising or bone marrow edema within the radius bone itself. The real power of MRI lies in its ability to depict non-osseous tissues, things like the physeal cartilage itself, the primary metaphyseal spongiosa, and importantly, that bone marrow edema or BMO. These structures are crucial for understanding the earliest stages of the injury process.
And you mentioned new protocols. This sounds interesting.
Yes, this brings us to the AMPHYS protocol, which stands for the Amsterdam MRI Assessment of the Physis. This protocol was specifically developed and validated to systematically assess the distal radial and ulnar paraphyseal area in both gymnasts and non-gymnasts. It's a significant advancement because it provides a concise, patient-friendly approach. The scan time is typically less than 15 minutes on a 3T scanner, which is fantastic for these young athletes. The protocol itself comprises 12 specific items we assess for the radius, each demonstrating good content validity and, importantly, fair to excellent inter-rater and intra-rater agreement. That means different radiologists can consistently interpret the findings, leading to more reliable diagnoses.
So it's standardizing the assessment.
Exactly. It's not just about fancy MRI sequences. It's about a systematic approach that helps ensure we don't miss crucial early indicators that can profoundly impact a young athlete's career. Among these 12 items, we're looking at several critical characteristics. Firstly, epiphyseal and metaphyseal bone marrow edema. We assess its extent, its location, signal intensity, and even its visibility on advanced sequences like 3D Woptics. Now, it's important to note that BMO can actually be present in asymptomatic children, which highlights the need to differentiate between a normal physiological stress response and a true injury. However, characteristics like the signal intensity and the extent of the edema can certainly help us make that differentiation.
That's a crucial distinction to make. What else does AMPHYS look at?
Secondly, physeal thickness. An increased thickness suggests disrupted enchondral calcification, and the AMPHYS protocol includes a unique and highly practical method of comparison. It suggests comparing the distal radial physeal thickness to the proximal physis of the first metacarpal bone, the thumb metacarpal. This serves as an excellent internal reference because it experiences significantly less axial loading in gymnasts, providing a more reliable baseline for comparison.
That's quite clever, using an internal reference like that.
It is, yes. Thirdly, we look at physeal signal intensity. Changes here can also indicate injury. And finally, metaphyseal intrusions, often described as physeal cartilage tongues, extending into the metaphysis. The protocol assesses their presence and depth. Reliability for detecting their presence is moderate to almost perfect, with good agreement on their depth. It also assesses the irregularity of physeal borders, particularly on the metaphyseal side, which is more frequently affected due to its crucial role in chondrocyte calcification during bone lengthening.
So the AMPHYS protocol really helps tie everything together for a more uniform assessment.
Absolutely. Its contribution to orthopedic practice is substantial. It facilitates a uniform assessment and reporting of suspected physeal stress injury on MRI, which streamlines clinical practice and significantly aids ongoing research into these conditions. It helps standardize the language we use, ensuring consistency across different clinical settings, which is vital.
That level of detail and standardization in MRI assessment is incredibly impactful for managing these cases precisely. Understanding the pathology and getting an accurate diagnosis is one thing, but to truly guide our clinical approach, we need to categorize the severity of gymnast's wrist. Are there distinct stages that help us tailor our treatment plans?
Yes, absolutely. Staging is crucial because it directly informs our clinical approach and helps us anticipate the likely progression and the required intensity of intervention. We typically outline 3 main stages, with a subclassification within Stage 2, which correlate both with the clinical presentation and the radiographic findings. Stage 1. This is often the earliest presentation. Clinically, the gymnast experiences that radial-sided or thumb-side pain in the wrist. However, despite these symptoms and a clinical diagnosis, there are no changes visible on standard X-rays. This really highlights the value of a detailed clinical exam and a high index of suspicion.
Right, so pain is the only indicator initially.
Exactly. Then we move to stage 2A. At this stage, the pain remains primarily radial-sided. When we perform X-rays, however, we now start to see visible changes. These typically include widening and/or sclerosis of the radial growth plate. The widening indicates the physis is struggling under load, and sclerosis suggests that hardening response in the adjacent bone.
Okay, so X-ray changes appear in 2A. What about 2B?
Stage 2B. Here, the pain pattern starts to broaden a bit. It's still mostly radial-sided, but the gymnast may begin to experience some ulnar-sided or pinky-side wrist pain as well. This is a critical indicator because it suggests the condition is progressing. Radiographically, we observe that the radial growth plate has started to show signs of premature closure, meaning portions are turning into bone, and the ulna bone may appear to have begun to lengthen relative to the radius, sometimes appearing ulnar neutral at this point. This is an early warning sign of that potential differential growth.
And the final stage?
Stage 3. This is the most advanced and concerning stage. The gymnast will typically experience both radial and ulnar pain, often with the ulnar pain becoming more prominent. Critically, on X-rays, the radial growth plate has fully closed prematurely. Meanwhile, the ulna has continued its normal growth, resulting in what we call ulnar positive variance, where the ulna is now definitively longer than the radius. This structural discrepancy, as we discussed, can lead to chronic pain and functional limitations due to that altered force transmission across the wrist. Understanding these stages allows us to communicate effectively with the athletes and their families about the severity, the prognosis, and the necessary commitment to the treatment plan.
That level of detail and categorization is truly vital for precision in managing these cases. So with that comprehensive picture from clinical exam, imaging, and especially now with the insights into staging, we're ready to formulate a treatment plan. What's our first line of attack, and how do we approach these cases long term? What are the immediate steps we should take, and what long-term strategies are crucial for ensuring a full and successful recovery, particularly focusing on the role of activity modification?
Right, treatment. The cornerstone of treatment for gymnasts' wrist is emphatically non-operative, especially as the first line of intervention. And at the heart of non-operative management is rest. And I mean proper rest. This isn't just reducing activity. It means complete rest from any activities that provoke pain, particularly those involving weight bearing through the wrists. The duration of this rest period can vary significantly depending on the severity, ranging from perhaps 3 to 6 weeks for mild cases to several months for more severe presentations. I've seen parental accounts, for instance, highlighting cases where severe bilateral conditions required 12 weeks or even up to 6 months of complete rest from weight-bearing activities to achieve full resolution.
That's a long time for a young athlete.
It is, and it requires significant buy-in. It's a crucial point to impress upon athletes and their families. Long-term damage is almost universally a direct consequence of ignoring pain and continuing to push through impact activities. I remember a case where a young athlete, initially very reluctant to rest, later reflected how much that early discipline ultimately saved her competitive career.
So rest is paramount. What else initially?
Alongside rest, we often employ medications. Non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen, are commonly used to help manage pain and reduce the inflammation in the growth plate. Immobilization is another key initial intervention. This typically involves using a brace, a cast, or maybe a splint for a period of, say, 3 to 6 weeks. The purpose here is to further reduce pain and inflammation by limiting movement and stress on the affected area. There are various specific wrist supports available for skids, Tenacordo 2A, Dunjoy, Gibson Easy Wrap, Tiger Paws are some names you might hear. They provide external support and perhaps some proprioceptive feedback.
And local treatments like ice.
Yes, cold therapy is highly effective for local pain and inflammation. Applying ice packs or doing ice massage for 10-15 minutes every couple of hours is recommended, particularly after any activities that might aggravate symptoms, even limited ones. Conversely, heat therapy can be beneficial before initiating stretching and strengthening activities later on, helping to warm up the tissues and improve elasticity.
And is surgery ever needed?
Well, while non-operative management is absolutely the primary approach, there are rare instances where operative intervention becomes necessary. This is typically reserved for cases where that premature physical closure has unfortunately occurred.
That makes perfect sense. Prioritize conservative measures first, with surgical intervention only when absolutely necessary and clearly indicated. So, looking beyond the acute treatment phase, prevention is always key, especially in young, developing athletes. What specific exercises and broader strategies can we recommend to help keep the wrists strong and resilient, both for preventing this condition and as integral components of a comprehensive rehabilitation program? Can you walk us through some specific exercise categories like flexibility, strength, and stabilization?
Absolutely. Prevention and robust rehabilitation really do go hand in hand to safeguard these athletes. The general principles revolve around intelligent training and consistent physical preparation. This includes maintaining appropriate overall conditioning with a particular focus on forearm and wrist muscle strength, endurance, and flexibility. It's crucial to appropriately warm up and stretch before every practice or competition seems basic, but often overlooked. Athletes should exercise moderately, avoid extremes, and always allow for appropriate rest after vigorous exercise. Critically, using proper technique when performing upper extremity weight-bearing gymnastic skills is non-negotiable. Specifically, avoiding elbow hyperextension is vital to minimize undue stress transferring down to the wrist.
Hmm.
Furthermore, strengthening the parascapular and rotator cuff muscles, the muscles around the shoulder blade and shoulder joint, can help distribute upper body load more effectively, taking some pressure off the distal wrists.
Right, strengthening the whole kinetic chain.
Exactly. Now, for specific exercises, we can categorize them into flexibility, strength, and stabilization, drawing on established rehabilitation principles. For flexibility and stretching, wrist stretch on the ground. This is excellent for developing the wrist extension needed for handstand skills. The athlete places their palm flat on the ground, fingers pointing forward. They take their other hand and position it in the crease between the pointer finger and thumb of the stretching wrist. They then apply gentle pressure downwards and backwards, rocking their body forward while ensuring the palm remains completely flat on the ground without lifting. This creates a good stretch in the wrist flexors. Wrist flexion extension stretches using a table edge. The gymnast hangs their wrist over the edge of a table. For wrist flexor stretching, the palm faces up, and the other hand gently pulls the hand back towards the forearm. For wrist extensor stretching, the palm faces down, and the other hand pulls the hand downwards. Each stretch should be held for maybe 30 seconds, performed for 3 sets. Range of motion exercises using a table press. For wrist extension, the palm is flat on a table with fingers pointing backward. The gymnast presses down, bending the wrist and straightening the elbow to feel a stretch. For wrist flexion, the back of the hand is flat on the table, fingers pointing away, and they press down, bending the wrist and straightening the elbow. These help restore and maintain full wrist range. Supination pronation. With the elbow bent to 90 degrees tucked into their side, the athlete turns their palm up as far as possible. Supination holds, then turns it down as far as possible. Pronation, holding each position. This ensures that rotational flexibility of the forearm is maintained.
Okay, those cover flexibility well. What about building strength and stability?
Moving to strength and stabilization. Inchworms. This is a great full-body exercise that significantly benefits handstand skills and builds dynamic wrist strength and stability. Starting standing, palms flat near the toes, the gymnast slowly walks their hands out to a push-up position, maintains core stability, then walks their feet back up to meet their hands. We typically recommend performing 3 repetitions, covering about 25 feet or so. Medicine ball push-ups. These are excellent for targeting the wrist stabilizer muscles. The gymnast places their hands, with fingers open, on 2 medicine balls of similar size, adopting a push-up position. They then slowly lower down and push back up, focusing on keeping their elbows tight to the body and maintaining a very slow, controlled movement. This really challenges the wrist's ability to balance and stabilize. Perhaps 3 sets of 8 repetitions would be a good goal. Plate or kettlebell circles, ideal for strengthening and stabilizing wrists post-injury. The athlete grabs a light plate or kettlebell, rests their elbow on a table, forearm vertical, and performs small, controlled circles with the weight, both clockwise and counterclockwise, maybe 30 times in each direction. Repeat for 2 sets. Targeted wrist strength. This involves using light weights or resistance bands for specific wrist flexor and extensor movements. For ulnar and radial deviation, a hammer held vertically or resistance tubing can be used. Grip strength can be improved with therapeutic putty or squeezing a softball. The progression here is absolutely key. Gradually increasing repetitions and weight under the guidance of a therapist or coach is essential to avoid re-injury.
That's a thorough set of exercises. What's the single most common mistake you see athletes make when performing these, especially as they're returning to sport?
The most common mistake, and it's a critical one, is trying to do too much too soon. It's that classic "I feel better, so I must be fine" mentality. The pain may have subsided, but the growth plate itself needs adequate time to heal structurally and adapt to load again. Rushing back is the quickest way to cause a setback.
Which leads us perfectly to the return to sport protocol. This meticulously phased approach required is particularly critical for us as medical professionals overseeing these young athletes. Can you walk us through the phased gymnast wrist return to gymnastics protocol, detailing the careful progression needed at each step? What are the absolute non-negotiables to ensure a safe and successful reintegration into high-level activity?
Yes. This phased return to sport protocol is, without doubt, the most critical element of long-term management. It's where a deep understanding of the condition really comes into play for practitioners. The overarching principle is that a gradual return to sports is permitted only after inflammation has completely resolved, any X-ray abnormalities have normalized or significantly improved, and full wrist motion and strength are fully restored. Pushing too quickly, as we just said, is the primary driver of recurrence and those potential long-term complications.
Okay, so let's bring it down. Phase one.
Right. Phase 1, rest and healing. This typically runs from diagnosis for about 4 to 6 weeks. This is the initial, absolute, non-negotiable period of true immobilization and rest for the wrist. Physical exam guidelines. During this phase, the gymnast will still present with tenderness to palpation on the distal radial physis and likely pain with weight bearing and wrist extension. Active and passive wrist extension will also probably be painful. No. Imaging guidelines. We'll get those baseline x-rays at diagnosis, PA 90-90, lateral, oblique, maybe contralateral. They might show that widening, early closure, sclerosis, parrot beak, or ulnar positive variants we talked about. Bracing cast. True immobilization is crucial, usually for the full 4 to 6 weeks. Range of motion. There should be absolutely no wrist motion. Complete rest of the wrist is enforced. The focus shifts to maintaining mobility in unaffected areas, thoracic spine mobility, pectoralis stretching, shoulder mobility exercises that don't load the wrist. Strength. Absolutely no strength training at the wrist joint itself. Instead, attention is given to strengthening the rotator cuff and parascapular muscles using exercises that do not load or stress the wrist. Modalities like gentle forearm massage away from the physis and massage to the thoracic spine, upper traps, and back can be used for comfort and to maintain tissue health elsewhere. Gymnastics specific. Week 1 is typically complete rest from all gymnastics. From week 2 onwards, caution is vital to avoid compensatory overuse injuries and other body parts. Conditioning focuses on legs, core, and back. Gymnasts can engage in non-wrist-bearing skills, things like leaps, jumps, turns, kicks on the tumble track, trampoline floor, and low beam. Later in this phase, maybe week 3 plus, skills like back tucks, front tucks, and aerials might be introduced if the athlete is not in the cast, but this carries risks the patient and family must understand and accept the potential fall risk onto the wrist. Progression to phase 2. This is permitted only when strict criteria are met. No pain to palpation or during hanging on the distal radial physis, no worsening on follow-up x-rays, and critically explicit clearance by the medical provider.
Okay, so strict rest for the wrist, focus elsewhere, then strict criteria to move on. What happens in phase 2?
Phase 2. Hanging and closed chain non-weight-bearing exercises. This phase typically lasts 2 to 6 weeks, potentially overlapping with the end of phase 1 as the cast comes off. This phase introduces controlled loading while still avoiding full weight bearing through the hands on the floor. Physical exam guidelines. Crucially, the gymnast should no longer be tender to palpation on the distal radial physis, nor should they experience pain with weight-bearing simulation or actual hanging on the physis. Active and passive wrist extension should also be pain-free. Imaging guidelines. Follow-up x-rays may be performed, ideally showing improvement at the distal radial physis, or at least a similar appearance without any worsening. Bracing cast. The cast or brace is discontinued in this phase. Range of motion. Now we begin active and passive wrist, elbow, and shoulder motion, aiming to achieve motion within, say, 5-10 degrees of the uninjured side. Continue with the thoracic and pectoralis mobility work. Strength. Begin gentle intrinsic hand and wrist strength exercises, forearm, biceps, and tricep strengthening. Continue with the parascapular and rotator cuff work. Continue with modalities like forearm massage if helpful. Hanging protocols. This is a central component of phase 2. First, you establish the gymnast's maximum baseline for various hanging durations. e.g., maybe they could do a straight arm hang for 60 seconds. Then, begin at roughly 70% of that maximum for 3 repetitions. Perform these 3 to 5 days per week, progressing very gradually perhaps by 2 to 5 seconds, or repetitions daily as tolerated. Emphasis must be placed on slow, controlled, proper form. Specific hanging exercises often include straight arm hang with scapular activation. Goal, maybe 3 sets of 60 seconds. Scapular pull-ups. Goal, 3 sets of 20 repetitions. Front reverse grip chin hold. Goal, 3 sets of 30 seconds. Chin-as pull-ups. Goal, 3 sets of 5 repetitions, focusing on slow, 5-second eccentric, concentric phases, using resistance bands for assistance if needed. Leg lifts.
tuck or pike variations. Goal: 3 sets of 10 repetitions, maintaining that active scapular hang. Progression to phase 3. This requires completion of the entire hanging protocol with absolutely no pain and meeting the specific number goals, alongside continued absence of pain to palpation or hanging on the distal radial flexus.
That hanging protocol sounds like a really structured way to reintroduce load tolerance. Then phase 3 is getting back to weight bearing.
Exactly. Phase 3. Open chain and weight-bearing exercises. This is the longest phase, typically for 12 weeks, sometimes longer, building carefully on the previous phases. This is the gradual reintroduction of the sport-specific demands. Physical exam guidelines. The gymnast must consistently demonstrate no pain to palpation or weight bearing, have successfully completed the handing protocol, and possess wrist range of motion and strength within those target ranges, 5, 10 degrees, and 10% respectively, of the contralateral uninjured side. Imaging guidelines. A follow-up X-ray is typically recommended at around 6 months from the initial diagnosis to check on the physis. Brace cast. Wrist guards might be considered temporarily during the initial return to weight-bearing skills, but ideally only for a short period as strength returns. We don't want them becoming a crutch. Range of motion strength. Continue all previous exercises to maintain and build on the gains achieved. Compression weight-bearing protocols. This follows a very carefully graduated progression. Start with plank handstand progressions. Begin with holding a standard plank on the floor, aiming for 3 sets of 15 seconds initially, gradually increasing duration towards, say, 100 seconds. If any pain or significant soreness occurs, stop immediately. Start with plank handstand progressions. Once a 3 by 20-second plank is comfortable, progress to a pike position with feet elevated on a block or box, aiming for 3 by 10 seconds initially, increasing towards 100 seconds. Start with plank handstand progressions. After mastering a 3 by 20-second pike hold, move to handstands against a wall. Start with 3 by 10 seconds, increasing towards 100 seconds. Start with plank handstand progressions. Finally, once a 3 by 20-second wall handstand is comfortable and pain-free, progress to attempting free handstands. Start with short holds, 2 by 5 seconds, increasing towards 30 seconds. Return to skill guidelines. This is highly specific and must be strictly adhered to. Limit all skills involving wrist weight bearing to 5 or fewer repetitions per skill, per event, per practice until full medical clearance is given. Detailed weekly progressions are usually outlined, tailored to the gymnast's competitive level, e.g. compulsory levels have different progressions than optional levels. Skills are gradually reintroduced on various apparatus, often moving from softer surfaces like pits or resin mats to firmer ones. This meticulous skill-by-skill reintroduction is essential. For instance, early on, a gymnast might start with low bar basics or non-flight beam work, eventually progressing over several weeks to vault handspring drills or more complex flight skills, always with that strict repetition limit per skill, per event, per practice.
That repetition limit seems incredibly important to manage the load. And what about monitoring pain during this phase?
Oh yes, the soreness rules. These are absolutely crucial for monitoring progress and preventing re-injury during Phase 3. They provide clear guidance for the athlete, parents, and coaches. Rule 1. No soreness. Great. Advance the protocol as planned for the next session. Rule 2. Sore during warm-up, but it disappears within 15 minutes. So don't regress today. Repeat the previous workout's level. If soreness returns during this workout, then stop. Take 2 days off and return at the activity level from 1 week prior. Rule 3. Sore for more than 1 hour after practice, or sore the next day. Take 1 day off completely, then repeat the most recent week of your gymnastics plan. Don't push through this. Rule 4. Sore during warm-up, and it continues beyond 15 minutes. Stop all gymnastics weight-bearing skills immediately. Take 2 days off and drop down to the activity level of the previous week. Rule 5. Sharp pain. Stop the activity immediately, inform an adult or coach parent, and make a note of the specific activity that caused it. If completely pain-free after 48 hours, try the skill again cautiously, maybe just once or twice. If the sharp pain returns, prompt follow-up with the sports medicine provider is mandatory before attempting again. Careful adherence to these soreness rules is absolutely what prevents minor irritation from escalating into a significant setback and potential long-term damage. It empowers the athlete to listen to their body.
The granularity of that return to sport protocol, especially those soreness rules, truly highlights the level of precision and patient education required from the medical team. It really is an intricate dance between pushing for progress and respecting the body's healing signals. As we wrap up this deep dive, what's the long-term outlook for these young athletes who experience gymnast's wrist? And crucially, what potential long-term complications might arise if this condition is not properly managed through these meticulous protocols?
Well, the good news is that the prognosis for gymnast's wrist is generally quite favorable, particularly when the condition is diagnosed early and treated appropriately with diligent adherence to the non-operative protocols we've just detailed. Early intervention really is key to preventing the progression to more severe stages and those potential permanent issues.
But the if not managed correctly part is worrying. What are those risks?
Yes, if not managed correctly, the potential for long-term complications is significant and can indeed be career-altering for these athletes. The most common and concerning complication is that premature closure of the distal radial fissures we keep mentioning. As we discussed, this leads to a shortened radius and consequently a secondary overgrowth of the ulna, resulting in that positive ulnar variance. This length discrepancy can cause persistent wrist pain, altered biomechanics, and increase the risk of other wrist pathologies like ulnar impaction syndrome over time. Other potential complications include a persisting loss of full wrist motion, which can be quite debilitating for a gymnast who relies so heavily on that range for their skills. Prolonged disability and chronic wrist pain are also real risks if the injury is repeatedly aggravated or poorly managed. In some severe cases, the growth plate can actually separate, leading to a Salter-Harris-type fracture, which then necessitates a different, often more aggressive treatment pathway.
And a very rare but serious long-term complication that has been noted in severe chronic cases is Kienbeck's disease. It's a vascular necrosis, essentially the death of bone tissue, the lunate bone, one of the crucial carpal bones in the wrist. This is a truly debilitating condition.
So the stakes are high for proper management.
They are. It's also worth noting that while our protocols aim for optimal recovery, individual experiences can vary. Anecdotal evidence, for example, from parent forums online, sometimes highlights cases where full resolution of severe bilateral distal radial epiphysitis was achieved after, say, 13 weeks of strict no-weight-bearing rest. Yet, in other instances, recovery took significantly longer, with some parents reporting 6 months or even more of no-weight-bearing activities before full resolution was finally achieved. This variability just underscores the importance of individualized care and continuous monitoring.
In follow-up, how long should we keep an eye on these athletes?
Long-term follow-up is absolutely necessary. We typically recommend monitoring these athletes for at least a year after the injury has resolved both clinically and radiographically. In some cases, especially in younger athletes with significant growth remaining, follow-up may be advised until all their growth plates are completely closed, ensuring that no late-onset growth disturbances sneak up on them.
What a fascinating and comprehensive deep dive into gymnast wrist. It's abundantly clear that understanding the intricate biomechanics and following a meticulous phased recovery protocol are absolutely paramount for these young athletes and, of course, for the medical professionals who care for them. The dedication required from the gymnasts, their families, and their medical teams to navigate such a precise return to sport pathway is truly remarkable and speaks volumes about the passion these athletes have for their sport. If you found this deep dive valuable, please do consider rating and sharing it with colleagues who might benefit. As we look ahead, here's a thought. How might advancements in things like motion analysis and real-time biomechanical feedback further enhance these already detailed return-to-sport protocols, ensuring even safer and perhaps more efficient recovery for our developing athletes?
That's an excellent provocative thought, and it really ties into the exciting future of sports medicine, doesn't it? If we connect this to the bigger picture, it highlights that continuous balance we strive for, pushing human performance to its limits in elite sports, while simultaneously safeguarding the long-term skeletal health of our pediatric athletes. Advancements in wearable sensors, maybe AI-driven motion capture integrated into training, they could potentially provide unprecedented real-time data on load distribution, joint angles, even subtle compensatory movements during training. This could allow clinicians perhaps to identify harmful patterns and potential overload risks even before symptoms arise, or to precisely quantify safe, progressive loading during rehabilitation in a way we currently can't. It moves us towards truly personalized, maybe even predictive, orthopedic care, constantly optimizing outcomes for these high-demand young athletes. It just underscores the evolving understanding of growth plate injuries and the absolute critical importance of multidisciplinary collaboration involving clinicians, coaches, therapists, athletes, and families in optimizing orthopedic outcomes for these talented individuals.